Okay, we're moving right along. Okay, now we're going to start into our opioid analgesics. These are used for moderate to severe pain. This is pretty much what we give to our post-op patients, patients in acute to severe pain. And both morphine and codeine are obtained from the opium poppy plant. So with that, we know that opioids act mostly on the central nervous system. Some receptors, such as the mu receptors, give it the analgesic effect. It helps with respiratory depression, gives you that euphoria, good feeling, as well as sedation. The other receptors, such as the K receptors, also help with the analgesia and sedation effect. It also has an antitussive effect, more so with our codeine. Um, that actually helps with cough. Antidiarrheal effect, and that's most of our opioids, which can cause constipation. So our first one that we're going to start with is our most common one. That's morphine sulfate or Duramorph or MS Contin. It can be given PO, IV, or IM, and it does act as a central nervous system depressant. It binds with the opiate receptors in the central nervous system, and it can become quite addictive. And it's used for severe pain. The side effects that we see is anorexia, nausea, vomiting, constipation, maybe some visual disturbances, disorientation, drowsiness, urinary retention, bradycardia, severe respiratory depression, hypotension, and increased intracranial pressure. So what I want you to do is look at opioids as one group heading. And under opioids, I want you to be able to identify that you have things such as morphine and codeine and Dilaudid and Percocet, Percodan, Vicodin. All of these opioids fall within that heading. Then I want you to look at the common side effects. With most all of our narcotics or opioids, I want you to think of opioids slowing everything down. It does act on the central nervous system. It does suppress the central nervous system. So what's going to happen to your heart rate if you are consistently on opioids for a long period of time? That can slow the heart rate down. Okay, and the heart rate gets slowed down due to a vasodilation effect. Morphine itself can help vasodilate the vessels to increase the blood flow, thus causing less stress on the heart, so the heart rate decreases, so bradycardia. Blood pressure itself, it can cause hypotension to occur with these opioids. The bowels, it slows the bowels down, which can lead into constipation. Remember, I just said an antidiarrheal effect. Mentation, the mental aspect, they become disoriented and drowsy, slows them down there. And then urine is another aspect of opioids. It can lead into urinary retention. So let's see those common themes pulled out as we go forward. Codeine sulfate, okay, it can be given PO, IM, or sub-Q. It's very similar to morphine. The analgesic potencies overall is about 1/6 of that of morphine. It does have an antitussive activity, less than morphine, but it's what we typically see in cough syrup is codeine. It's used for mild to moderately severe pain. It can suppress non-productive coughs. You may see codeine combined with Tylenol, and the name of it would be Tylenol with codeine or Tylenol number 3. That is the name that they've given Tylenol with codeine, is Tylenol number 3. So if you see that, you know it's a pain medicine that has codeine plus the non-opioid analgesic, which would be Tylenol. So you want to make sure that they don't exceed the 3 grams per 24 hours of Tylenol. you want to make sure that your patient doesn't take Tylenol in conjunction with Tylenol number 3, because then they'll be getting too much Tylenol. Side effects of codeine would be hypotension. It can go into some palpitations, nausea, constipation, dizziness, drowsiness, pruritus, which is itching. We do see that as a common side effect of most narcotics, urinary retention, and in worst case scenario, anaphylaxis. Hydrocodone can also be called other names such as Vicodin, Lortab, and Vicoprofen. Well, hydrocodone is like a codeine derivative that is more addicting, and it has greater antitussive and analgesic effects. So hydrocodone we do see given with cough, and it's named Vicodin when you mix hydrocodone with acetaminophen. It's named Lortab when you mix aspirin with hydrocodone, and it's called Vicoprin when you mix, or Vicoprofen when you mix ibuprofen with hydrocodone. So you're going to need to decipher as what is that non-opioid additive with this hydrocodone. Is it acetaminophen, is it aspirin, or is it ibuprofen? It's used for moderate to severe pain and antitussive effects. Side effects is constipation, nausea, vomiting, drowsiness, euphoria, respiratory depression, and pruritus. So are you seeing the commonalities here? All right, with the opioid Dilaudid, it's also called hydromorphone. This is actually the drug of choice now. This is what we're seeing more readily prescribed than we are the morphine for our severe to moderate pain. It can be given PO, sub-Q, IM, IV, and rectal. The action of Dilaudid is very similar to that of morphine because it is a semi-synthetic derivative of morphine. It's 8 to 10 times more potent than morphine with a rapid onset. But that rapid onset means that we are going to probably have a shorter duration. So with that being said, as the patient calls, they ask for pain medicine. Well, if they're in need of pain medicine now, it's going to have a quicker onset to help relieve that pain. The downfall is it's not going to last. So it's not going to last as long, which means that your patient's going to be asking for more pain medicine, and it will not be long. The good thing, another benefit of Dilaudid, is it's less hypnotic, which means that the patient is more alert and with it, especially in the post-op period, and not as drowsy and drugged as you would have seen with morphine. Common side effects is constipation. There are some sedation, but again, it's less, it's shorter duration of that sedation. Euphoria, hypotension, respiratory depression, blurred vision. So why not give Dilaudid in the post-op period? We'll treat the pain quicker. We'll have less hypnotic effect. They'll be able to get up and move and walk and heal a lot quicker because the use of it thereof. Demerol or meperidine is also another narcotic, and I've kind of put it at the end because Demerol is kind of being phased out. Demerol used to be the drug of choice, gosh, maybe 15 to 20 years ago. And we used to give it IM as well as IV. And we were given Demerol and morphine kind of equal, one or the other. But now they're finding that Demerol is not as effective IM as they once thought it was. So they've kind of been pulling away from giving Demerol. I will say you do see Demerol still used for conscious sedation at Vidant and Greenville. There's some other possible potential choices, but you might see Demerol given as a conscious sedation method rather than just for pain management. Oxycodone is a semi-synthetic derivative with the action similar to that of morphine as well. As potent as morphine, 10 to 12 times more potent than codeine. So oxycodone is very beneficial. It's used for moderate to severe pain, and it's most effective in the relief of acute versus chronic pain. So let's treat the here and now as opposed to the chronic. Side effects: euphoria, sedation, constipation. Hepatotoxicity, especially with acetaminophen dosages, because oxycodone can be mixed with acetaminophen, and if it is mixed with Tylenol, it is called Percocet. If it's mixed with aspirin, it's called Percodan. Percocet is the drug that a lot of drug seekers are selling on the streets. This is what people will go and complain of pain. They'll get drugs and then go sell them. And that's such a misfortune. That's overuse and overabuse of something that could be beneficial. Fentanyl is, and we've talked about fentanyl in the past, I do know of. It's IMPO. Can be given IV, especially for conscious sedation. I believe fentanyl is what I had for wisdom teeth to be cut out. Transdermal, and fentanyl we usually see in a transdermal aspect or a durgesic patch, and that's probably the most familiar that you will see, other than the aspect of the IV if you work with sedation. So the action is synthetic, similar to morphine, but more potent. It's about 75 to 125 times more, with a quicker onset and shorter duration. So the transdermal is very beneficial because it'll actually leak medicine out at a certain rate every so often, just because it's in a patch form. It's used as an adjunct drug to general and regional anesthesia and for breakthrough pain, especially with our cancer patients. We actually prescribe the durgesic patch to help them for that breakthrough pain, and then they might take something in conjunction with that. It might be sublingual morphine to help them with the pain as well. Side effects, pretty much the same. I'm really not going to go into that. All right, we also have methadone. Methadone is a very good drug. It is highly addictive, which cannot be good, but we have found something good for it. Okay, so methadone can be given PO, sub-Q, IV, or IM. It is a synthetic derivative similar to morphine, but with longer duration. It lasts longer. Okay, it's highly addictive and it lasts longer, but the withdrawal symptoms are less intense. So now we have found some good in this. The use of methadone is for severe pain and detoxification. So what we do is we send the patients to a detox center. While they're there, we are going to give them methadone, which makes it's highly addictive. So they're going to get addicted to the methadone to come off whatever their addiction is. When they come off their addiction, then we need to get them off the methadone because they have less withdrawal and it's less intense. So it's kind of, let's get them addicted to methadone to take them off the addiction of something else. And then once they are completely off the something else, then we'll take them off methadone. And their withdrawal symptoms will not be as intense. I will say, in my experience, the withdrawals from alcohol, the withdrawals from heroin that I have witnessed has been very tormentous to even take in.